Hi, everyone. Thanks for joining us today. My name is Jasmine, and it's my pleasure to introduce the first of our Bruyère Talks research webinar series for 2021. First, I just want to note that this presentation and the discussion are being recorded and they'll be available later. We'll also be taking questions at the end of the session, so you can submit written questions throughout the presentation via the Q&A icon at the bottom of the window, or you can use the raise hand icon to ask the question live during the Q&A portion itself. And feel free to message your fellow attendees throughout the session in the chat box. With that said, I'd like to introduce our speakers today, both physician researchers in palliative care, Dr. James Downar and Dr. Peter Tanuseputro. Dr. James Downar is a critical care and palliative care physician in Ottawa and is an investigator with the Bruyère Research Institute. He's also the head of the Division of Palliative Care at the University of Ottawa, where he is an associate professor in the Department of Medicine. He holds a research chair in palliative care and end-of-life care. Dr. Downar co-chairs the Pan-Canadian Palliative Care Research Collaborative and the Ontario Palliative Care Network's Provincial Education Steering Committee. He's also chair of the Ethical Affairs Committee of the Canadian Critical Care Society. His research interests include communication and decision-making for seriously ill patients and their families, as well as palliative care for the critically ill, and including non-cancer illnesses. Dr. Tanuseputro is also an investigator with the Bruyère Research Institute, as well as the Ottawa Hospital Research Institute. He's an assistant professor with the Division of Palliative Care in the University of Ottawa's Department of Medicine, and holds a research chair in palliative care and predictive analytics. As a physician, he practices family medicine in the Ottawa community with a focus on palliative home visits. And as a researcher, he focuses on using linked health administrative databases to develop population perspectives on healthcare use and outcomes associated with aging and end of life in Ontario. With our speakers introduced, I'd like to now turn it over to Dr. Downar.
Good morning. Thank you, Jasmine, for that introduction, and I really appreciate everybody joining us today. So I guess without any further ado, we'll dive right into it. You go to the first slide, please. Great. A reminder, the webinar is being recorded. So just some disclosures from my end. I've had some speaker fees from different pharmaceutical companies unrelated to the topic that we're going to discuss today. I had some consulting fees from for educational material development unrelated to this project as well. And now also some grant funding from CIHR and Clinical Frailty Network or Canadian Frailty Network related to this project as well, which I'm going to declare, but I don't believe there are any conflicts of interest or any biases to mitigate. Next slide, please. So the objectives for today, first of all, we're going to talk a bit about the importance of timely identification for patients who have unmet palliative needs, but then talk about the limitations of our current approaches and how we do this, and then propose some newer, make you aware of some newer automated systems about timely identification, how these could be used to drive quality improvement in end-of-life care. Next slide. So always good to start off a talk where you try to sort of describe the problem as you see it. And I always love being able to do that. Unfortunately, this is table 4 of this paper, which I think was the most important piece of data in this paper. But it's a very important paper that I think if you haven't read, you should probably grab for a moment and just take a quick gander at. And it really looks at the involvement of palliative care in people in Ontario based on their trajectory and different aspects of their condition and demographics. And it really, I think, in this one table, this one section of the table that I've lifted here, I think encapsulates the problem as you might see it. So if you look at how we are doing in terms of the involvement of palliative care in Ontarians as they approach the end of life, it really varies according to what kind of condition you have. So if you look at terminal illness, which is sort of a catch-all group that would include cancer, mostly cancer, but also a condition like ALS, for example, you know, about almost 90% of them are getting some involvement of palliative care at some point before they die, which is not bad. It could be, obviously 100% would be better, but 90% is not that bad. And about 2/3 of those, a little more than 2/3, are getting it at some point in the community before they die. And that's where we want. We want people getting palliative care and getting it ideally in their home environment too, which is great. Median days between first palliative care and death, 107. So that means about 3.5 months before you die, you're getting your first encounter with palliative care, and you're getting it on average 37% of days. So about 1 day in 3, you're seeing somebody about something to do with palliative care. So those aren't terrible numbers, frankly. I mean, again, these are median numbers and average numbers, and obviously there's still a fair number in this group who aren't getting good numbers. But as a whole, if those were your numbers, I think you'd be doing pretty well. And certainly the room for improvement is smaller than it would be, for example, for the other two trajectories on this, organ failure and frailty. So organ failure would be something like congestive heart failure, COPD. And again, now you see involvement of palliative care cut in half. The number getting involved with palliative care in the community is about 1 in 6 instead of 2 out of 3. The median days, instead of 3.5 months, it's only 3 weeks. And instead of getting it every 3 days, you're getting it every 4 days. And frailty, the numbers are even worse than that. So it really makes it clear what the problem is, right? That you're not only getting, you do have obviously a gap in what would be considered an ideal state of involvement of palliative care and what's actually happening. But the gap, it's not spread evenly across society, and there's quite a big difference between, for example, terminal illness, organ failure, and frailty. And so if we're going to make a real improvement in end-of-life care and involvement in palliative care, not only do we have to do it a little earlier, but we have to really make sure that we can focus our efforts in that non-cancer realm. Next slide, please. Early identification has been identified in Ontario on a number of occasions recently. The Declaration of Partnership, Provincial End-of-Life Provincial Roundtable Report. Next slide. The OPCN action plan, it was an actual entire action item on it. And in the most recent palliative care quality standard that was released by Health Quality Ontario a couple of years ago, it was actually statement number 1 of the 13 statements, was the importance of identifying and assessing early needs. It's also been included most recently in QIPs, quality improvement projects mandated by the government for healthcare organizations and sectors across the province. So really quite a lot of importance put on early and timely identification. Next slide. And again, lifting this from the sort of gold standards framework approach that was sort of promoted in the UK, you can break down your sort of early identification and carry it through to the end through sort of 3 steps. You have your identification step, then your assessment step, plan and manage. So identification is identifying people who might benefit from palliative care early in the illness trajectory. Step 2 is to actually identify what specifically the needs are based on a sort of personalized assessment. And then finally, develop a plan to address those needs, close those gaps, and then deliver on that plan towards the end, right? But of course, it all starts with identification, right? So you can have really good palliative care, but if no one ever calls you or no one ever gets involved, then it's not going to be much good to anybody, right? And so it's really important to think about it in these terms, that sort of 3-step process. Next slide. So if you're going to do early or timely identification, it becomes important to ask yourself when early actually is. This is the bow tie model, which has been proposed by Pippa Hawley out in BC, which I'm personally a big fan of. I think this is the right way to look at the world. That as people get diagnosed with conditions, right, you have sort of 2 triangles. You have your disease management triangle in blue and your palliative care triangle in pink. And this sort of, as people start from the left side and move over to the right side, initially disease management is sort of takes pride of place. And then slowly as time goes on, as disease management becomes less and less effective or less relevant, palliative care is taking over more of a role. But there is considerable overlap, and pain and symptom management is relevant, obviously, regardless of what your goals of care might be. And then ultimately people may respond and improve, in which case they go towards rehabilitation and survivorship on the top, or they may deteriorate and decline and die, in which case you're going sort of down towards palliative care and hospice bereavement. So the continuum from left to right, is that you've got sort of, got to know when early is. When do you start the pink triangle, right? Do you start it right at the very start, right? Early, is it early-ish, earlier, not early? And there certainly is the concept of what we call the Goldilocks phenomenon, that there is such a thing as too early. So, trying to get palliative care involved early, for example, at the moment of birth or in a time of perfect health, people are just not really going to engage very much in that. It's hard to take these conversations seriously when they're not in earnest. when people aren't really sure what conditions they're going to have and what issues they might face, right? You can talk about these things in generic terms, but it's hard for people to really engage in them. And it certainly could take a lot of your time. So if you have limited resources and limited opportunity, you know, you want to sort of pick your moment, and you obviously don't wait till too late, because then obviously the person's been suffering for a long time, and that's not good either, right? So this sort of Goldilocks phenomenon that you have to find it, the perfect spot right in the middle. And finding that perfect spot is harder than you might think. Next slide. And I was sent this by Daniel Kane from Kingston. It's my favorite poem called Timing Toast from Pete Hine. There's an art to knowing when, never try to guess. Toast until it smokes and then 20 seconds less. This highlights a really problematic, you know, trend, I think, in healthcare in general, but particularly around end-of-life care, which is that it's very easy to tell when you didn't do something right in retrospect, right? So for example, identifying people who might have benefited from palliative care once they're dead is easy, but not all that helpful. It's not useful. Like, you know, for those of us who've had, you know, poorly functioning toasters or made some mistake with toast, or those of us who grew up in an age before toasters had timers in them, it was very easy to screw up toast. And then, you know, you have this giant smoking mess and the smoke alarm's coming in. And invariably some family member will at that point walk into the kitchen and say, hey, dude, your toast is burning. And you're like, and I know my toast, thank you. Like, I really did not need you to tell me that toast is burning. By the same token, telling me that, you know, a patient, once they're deceased, you know, geez, you really should have done an earlier transition. Maybe we should have called palliative care. Okay, that's great. You know, a journey of self-discovery is always nice, but not very helpful for that person. That person is dead. What's much more helpful is having an anticipatory mechanism, something in place that might tell us at the time, at an actionable moment, what to do and when. Next slide. So obviously we'd love to turn to the literature if we can, right? Unfortunately, not very helpful. So great, this is one of my favorite systematic reviews, if you get a chance to read this. It was from Van Mechelen and colleagues, looking at 60 randomized controlled trials of palliative care, mostly cancer. Published RCTs have no clear definitions of their palliative care patients, and there was a lack of consensus concerning the attributes of illnesses needing palliation and the ambiguous use of the adjective palliative. Not exactly inspiring stuff, that it doesn't really, you know, if we're not really sure, we can't really agree on what it is and what we're doing it for, it's not obviously easy to tell when we should be doing it. So again, the studies might not be all that helpful. Next slide. Often in practice, we rely on sort of triggers, external triggers, and we are very reactive. Humans are by their nature reactive creatures. So often when it becomes apparent that the person has a very short prognosis, or perhaps we notice a functional deterioration or some new diagnosis or new finding of some nasty metastatic condition, and that might prompt us to suddenly think about palliative care, and does this person have palliative needs, and that would prompt us to develop a plan there. But relying on these triggers, as we've seen already, is a bit unreliable, and we can talk a bit about that now. Next slide. So prognostication is you know, identifying people with a short period of time to live is a bit of a challenge. So this is a study from Carl van Walraven, sort of publishing a review of some published prognostic models that look at different conditions that you might find in medicine. Now, for those not familiar with the C statistic, this is sort of a catch-all statistic to try to help you understand how accurate a test might be for predicting an outcome. So areas under the curve, or C statistics, range from 0.5 to 1. 1.0 is a perfect predictor. 0.5 is the worst predictor imaginable, like a coin flip. It's completely unlinked to the outcome. You like to see numbers in the high 0.8s and 9s, if possible. Anything in the low 0.8s to lower becomes very much less useful. And even using what are fairly, you know, complex prognostic models, you see that most of them sit in the 0.7, some of the 0.6, some of them creep up into the low 0.8s. But they're not in the range of what is extremely useful. And unfortunately, a lot of them involve a fair amount of work that you have to sit there and calculate numbers for every single person in front of you, which is more than a bit challenging. We're going to get to Homer at the bottom in a second. Next slide. So then there's functional impairment, which is often the thing that we might recognize as people start to really, functionally decline and need more help. That can sometimes be the trigger saying, oh, maybe this person's nearing the end of their life and I should get palliative care involved. Now, the concept of using functional impairment is certainly seen throughout our system, right? So if you're eligible for example, admission to a hospice or palliative care unit, often those admission criteria are based on functional status. And what's interesting here, so this is a very famous study by Tino and Lin, looking at functional impairment in the final year of life. So we're starting 12 months from death at the left side and moving towards the right side, that's 0 months from death or just prior to their death. The y-axis is the ADL score. So this is the number of activities of daily living that you need assistance with. So a functionally independent person is somebody with an ADL score of less than 1. Dependent people have an ADL score of above 1. And you can see that, let's follow cancer, which is the diamonds in the dotted line, which starts at the bottom. And you see that most people with cancer a year before they die are functionally independent. And as time goes on, there's very little change till about 4 months. And between 5 and 4 months, they cross from less than 1 to above 1 and become now functionally dependent. And there's quite an inflection point at about 3 months prior to death and a rapid rise in their degree of functional dependency. So this is a very common sort of changing trajectory and noticeable decline that you see. And that crossing the line from being independent to being dependent is very easy for us to notice. And we notice it quite reliably, which is great. So you'll see that often in home care and in palliative care programs, they say, okay, once you've got 3 months left to live, then you're eligible for more home care resources or to go to palliative care unit. And that's based on this actual model, right? The idea that these cancer patients tend to have that rapid inflection transition point at about 3 months to go. Now, the clever among you will spot the problem with this approach, which is literally every other condition on the slide does not conform to this model. So everybody with non-cancer illness who's dying of non-cancer illnesses, their ADL score actually starts out even 12 months before they die above 1. So most of these people have been dependent, the whole time and probably a long time before this. And even worse, they don't actually change all that quickly as they get towards death. There is a bit of a functional decline, but it's nowhere near as noticeable or dramatic as the functional decline you see in cancer. So if that's the pattern you're looking for, you're not going to see it. Unfortunately, these people have a lot of high needs. And so, as a rule, a lot of programs don't offer beds to non-cancer patients or are very reluctant to take non-cancer patients because they can fool you very easily into thinking that they're about to die when they're not. Next slide. So one of the more integrated approaches was to use this thing I've mentioned already, the gold standards framework, prognostic indicator guidance. They have a new term now. This is prognostic, I forget the term, but there's a new term for it. But it's essentially a 3-step process. You start off by asking yourself the surprise question. Would you be surprised if this patient died in the next 12 months? And then you look at what are called general indicators decline and specific clinical indicators that might help you decide whether you think this person's nearing the end of their life and could benefit from a palliative approach. Next slide, please. So let's talk about the surprise question. It's not that good. I think of the past 4 years hasn't cured you of the ability to be surprised by anything. Hopefully this next few slides will. Next slide. So we did a meta-analysis of the surprise question in clinical practice. So 16 published studies of over 10,000 patients looking at this, first of all, just the ability for the surprise question to actually predict who is dying and who is not dying. Now, if this is being used as a screening question, obviously you're going to want something that's relatively sensitive, picking up people who are dying. And right off the bat, you're seeing a sensitivity of only 67%. So this is fully missing a third of the dying. As a screening tool, having a low sensitivity is pretty much a deal breaker. That's bad. Specificity is not bad at 80%, but then when you start to get into the more functional measures of the utility of the tool, which is what people like, so things like likelihood ratios and positive predictive value, you start to see some bad numbers. So likelihood ratio of 3.4. So positive likelihood ratios, you like to see 4 and above, indicating a very helpful tool for ruling in a condition. And negative likelihood ratios of less than 0.25 or 0.2 are helpful for helping you to rule out a condition. And you can see that this test actually fulfills neither of those criteria. It's not particularly helpful for identifying the dying, and it's not particularly helpful for ruling out the dying. Positive predictive value of 37%. That means that of all the times you return a positive result from this test, only 37% of those people are actually in the final year of their life, meaning that 2/3 of the time this test goes off, it's actually identifying somebody, identifying the wrong people. So you're missing a third. 2/3 of the time you're getting the wrong people, the people you don't necessarily want. it's problematic, right? When you have a limited time and attention to spend on things. Again, following a trend, it's more useful in cancer. So positive likelihood ratio does get into the useful range, but that means that in non-cancer, it's almost completely useless. And seeing as 2/3 to 3/4 of the population dies of a non-cancer illness, using the surprise question could really send you down a lot of rabbit holes. Next slide. The other problem with the surprise question is the kappa. So interrelated reliability. How commonly do two raters looking at the same person return the same results? Turns out not that often. It's sometimes very, very much above random, not very much above random. And in finding, we've recently published in a study, Yarnell et al. Published in PLOS One this year, showing that sort of inter-rater reliability as a factor to predict the outcome was as great as any clinical factor of the patient. In other words, it's as much a personality test of the doctor as it is a prognostic test for the patient, which is a problem. In some studies, when they look at this in, for example, Catalonia, and they review practices, they return a positive result 83% of the time. It's not much of a screening test if it's giving you, if you're going to community practices and literally almost 80+% of the time you're getting a positive result. It really isn't screening anybody out. You might as well save your money and just buy a door chime because it's going to be almost as helpful. And of course, the NICE now in the UK no longer recommends the surprise question as a screening tool. It's been dropped from other UK tools like the SPICT. Next slide. So if we don't like the surprise question, we go on to the other aspects of the gold standards framework, which are sort of some general indicators of decline or specific clinical indicators that look at disease-specific states. Well, that's simple, because all you have to do is ask yourself a short list of 74 questions about literally every patient you see every day. I think when you look at a list like this, it becomes rapidly apparent that unless you've memorized this thing and unless you're really thinking about it all the time, this is not going to have a very high uptake, right? The ceiling on this is going to be low. And ultimately, when you compare the patients who are identified using the general indicators and specific clinical indicators, they're almost identical to the people identified by the surprise question. So you're doing all this work and you're not really getting any further ahead. So this is not a great approach. Next slide. So taking back to the paradigm, right? Again, remember, we're still looking for this reliable system to identify patients at risk of unmet needs that will drive proper assessments, developments of plan, and managing their care. Next slide. So I like to think of it as kind of like a reflex arc, right? So you start off here with the patient, the family at the top, and then on the right side, you go through this sort of afferent limb or sensory limb, if you will, identification and assessment, trying to figure out who has unmet palliative needs. And that gets brought to the attention of the healthcare providers who then deploy some intervention, the action and planning part, which is what we do about it on the going back up to the patient. So this is this reflex arc that you could think of in palliative care. So next slide. And a lot of barriers that impede us completing this reflex arc, right? So starting from the top and going clockwise, right? If the healthcare providers are overwhelmed, they're not going to be doing lots of identification and assessment. They're not going to do extra work for every person they see when the whole world is on fire and they're just running around like headless chickens. If they're unable to and they don't have adequate tools, that's a problem. If they're unwilling to and they don't think it's really their job but that they should be doing it, then that's a problem, obviously, as well. And if the tools themselves are inaccurate, then that's also a problem. All of these will impede the process of identification and assessment. Conversely, if you're able to sort of streamline things into existing workflow and try to find a way to kind of get a manageable workload on healthcare providers, then maybe you've got a chance of completing that section of the arc. There are also a lot of other sort of barriers that impede action and planning from the healthcare providers back towards the patients, right? So again, healthcare providers being overwhelmed, they can't really do a lot of action and planning if they're too busy doing other things. If they're unskilled at communication or treatment, then obviously that's a problem. If the families and patients may be unreceptive, there are certainly people who just don't ever quite embrace a palliative approach or ever realize that they are dying or accept that they're dying. And it's very hard, you can't change the light bulb unless the light bulb really wants to change. And of course, if you have no resources to deploy, well, that's a problem because there's nothing to do for them. And again, if there's poor communication among healthcare providers, the team kind of falls apart. I mean, there are lots of ways that this arc fails to work. But if we just focus on the afferent limb on the right side at this time, maybe we can get a little further ahead and work on the other stuff later. So next slide. So again, if you had an ideal state for how you might handle that afferent limb, that identification part, right, you'd have an accurate tool. I think accuracy, a lot of people sort of, when we published our surprise question systematic review, people pushed back and said, it's not meant to be accurate. It's meant to identify people with unmet needs. Well, there's absolutely zero evidence that it does that at all. It was the only data anyone's ever measured it against was its ability to identify people maybe nearing the end of life, and the data for that was quite concerning. It's not very good at that at all. I think inaccuracy is a problem. I don't concede this point. I think if you're getting a lot of false positives, it means you're putting your resources in areas that might not be the highest priority patients. And I think if you have if you're flagging 83% of your practice as needing palliative care, I think people are going to get to alert fatigue. They're just not going to act on these alerts anymore. I think you need to be reasonable in terms of what you're getting in terms of positive results. And then it needs to be a manageable workload. That's proving to be a huge workload factor as we implement across the province. False negatives are also a problem because, of course, you get untreated suffering, right? So accuracy is not a trivial point here. You need something that's not provider dependent because there's a lot of provider hesitancy to use tools. People are overwhelmed. Getting people to remember to do important but non-urgent tasks is a challenge, right? Most of us tend to wait until the last minute to do important, non-urgent things. It's not because they're not important, it's because less important, but very urgent things keep coming up and interfering with us. And that's sort of the axis of productivity. And the degree to which you cannot create new workload and new workflows for people, but actually use existing workflows is big, right? And this is where big data comes in, starting to use existing data in the system to try to flag people and use that in a way that might be helpful for us. Next slide. So enter Homer. Homer is the hospital one-year mortality risk score, which was developed by Carl Van Walraven here in Ottawa. And it's a highly accurate mortality prediction tool for patients in the 1 year after they get admitted, using data from data that's already in the electronic health record or in administrative databases, and getting a C statistic now of actually in excess of 0.9 in some studies, which is incredibly accurate. It's actually almost impossible to get a more accurate tool than this. And it uses very simple administrative data. The other nice thing is that it returns a number. It doesn't return a yes or a no. You can set a threshold wherever you want, but it's adjustable. So next slide. So we actually took the Homer model and then built it into a prospective process. So Carl designed this for use retrospectively to sort of standardize based on mortality prediction. But with slight modification, we were able to generate a model that could work in real time prospectively on new patients being admitted. And use that to flag patients when they got up and flag people who were in the highest, for example, 10 percentile of risk of mortality in the coming year, and flag those people for the admitting teams. And we were able to find that it was actually quite a feasible and helpful approach. Next slide. So we set a lower sensitivity but high specificity threshold to give us a really good positive likelihood ratio, and again flagging sort of 12 to 15% of all admissions at this one hospital. And again, we tried it one place where we were able to integrate it into the workflow for like their sign out sheets, and in others they didn't have the same workflow, so we had to send emails to staff, and we found that the integrated workflow was actually really quite effective. The emails to staff, not very helpful. Next slide. And what we found was, again, these were the patients we were flagging. So what we did was we had two phases where we were flagging people in the background and just seeing what happened to them. We didn't notify the teams that the patients were at high risk. And then we turned on the notifications, started flagging them to the teams, and saw what happened. So again, we're identifying patients who are usually on average in their 80s, people staying about a week in hospital. Only fewer than half of them had any limitation of care ordered at the time of their admission. And what was interesting was that at the site with integrated notification, when we turned on those notifications, the rate of consultation to palliative care or early family meetings almost doubled. Just with little flags. And again, it was really quite impressive. And what was also nice to see is that about 90% of these people survived to hospital discharge. So it wasn't, the last thing you want is a tool that tells you like 5 minutes from when someone's dead that they're going to die. That's not helpful. Identifying it in advance when you still have time to intervene, that's what you really like. The other really nice thing about this is that more than half of the patients that flagged actually had a frailty condition, and only 20% had cancer. So we talked at the start about not only identifying people in a timely manner, but helping us in areas where we're weak, which is organ failure and frailty. And this tool seems to do that very well. It flags people with organ failure and frailty. Next slide. And again, so we went on to a second study where, some people wrote back on this, well, just because they're at elevated risk of death doesn't mean that they have unmet palliative needs. This is potentially true. Let's go find out. So we did a prospective study where we looked at patients who were flagged by Homer to see, do these people have palliative needs if they have high thresholds? And then we asked, was there anything magical about the threshold that we picked? If we took a lower threshold, for example, of mortality risk, so more sensitive, more positives, but more false positives, are we going to start to see a tail off in terms of unmet palliative needs? Next slide. And again, I just can go through very quickly here. Again, we found, that obviously with a lower threshold, we were flagging a lot more people. The cold approach actually was very well accepted. So, more than 3/4 of people we approached are perfectly happy to participate in the study, unmet palliative needs. Nobody was freaking out about this. Next slide. And what we found was interesting. So at the 2 thresholds, right? So this is sort of a tableau looking at again, breaking down by trajectory. Blue is people with frailty, red people with organ failure, yellow people with cancer. And then dark blue versus light blue is those with unmet palliative needs versus no unmet palliative needs. And you can see that the overwhelming majority, regardless of what they had some degree of unmet palliative needs, either a desire to discuss advanced care planning with the staff or one or more severe symptoms. And then even at the lower Homer scores, so the slightly lower mortality risk, again, you'll see that there's far fewer frailty, far more cancer and organ, and about the same number of organ failure. But again, we're still very much identifying people with high prevalence of unmet needs, and the difference between the 2 groups was negligible. So these, we're definitely picking up, even at lower thresholds, patients who have unmet palliative needs. Next slide. So again, just as a sort of wall of balls, people concerned about workload, right? So if you use the higher Homer threshold like we did, of every 100 admissions to GIM, right, you'd flag about 9 of them, 9 or 10 based on the studies that we did, right? So these ones in gray. And of the 9 you flag, 1 patient will have no unmet palliative needs. That's the one in white. The one in red has an elevated symptom score. The one in blue has a desire to engage in advanced care planning. And the remaining 6 have both a desire to engage in advanced care planning and an elevated symptom score in the severe range. So of these 9 patients, 8 of them clearly had unmet palliative needs. And of all the mortality of all the people who are going to die in the next year in this 100, just these 9 people account for about 60% of the mortality risk in that group. So it's a pretty decent way of focusing your attention on a high yield population. Next slide. And at this point, I think I'm going to hand things over to my colleague, Dr. Tanuseputro, to talk about a very similar model that he's also using in long-term care and home care. So take it away, Peter.
Thanks, James. As James said, the respect tool. So I'm going to be talking about our respect tool, and you can see the team members there that created the respect tool. The respect tool is, sort of a complement to the Homer tool that James is creating for the acute care setting. I think everyone sort of recognizes that, being in acute care and being in mid and acute care is a really nice inflection point where you have, a captive audience for the patient and caregivers, where you can sort of alter the trajectory of the care that they're receiving post-discharge. But what we wanted to do is complement that and go a bit more upstream and downstream to look at the care that people are getting in the community settings. I think everyone recognizes that most people want to be at home. They might not necessarily want to die at home all the time, but the majority of people, when asked, do want to spend the majority of their time when they're dying at home. And so what we've done is similar to Homer. We've taken existing routinely collected data, and we created a predictive algorithm for survival to sort of give information back to individuals who are receiving supports in the community about their prognosis. And if you can go to the next slide, this is the protocol if you ever want to look at the details about what we've done. But this is the respect tool, or sort of the logo for respect. We do have a website tool that we've created to accompany our respect tool. And if you go to the next slide, please. And what I'll do, I'll trial the website today for those of you who haven't seen previously. I know some of you have seen respect before. But before I do that, I'm just going to explain how we created the model and the data that's used to collect or that's used to prognosticate people's survival. And so with respect, the outcome that we're thinking about is survival time. If you can just kind of just go through all the bullets, that would be great. Perfect, one more bullet. And the data that we're using is home care assessments. So before anyone receives home care in the community, they do get a RIE assessment. And the resident assessment instrument assessment essentially asks a whole host of questions, over 300 questions, about the person's function, health, and needs. And all of that is to determine people's eligibility for home care services and what kind of services they need. So what we've done is we've taken data from the RIE assessments, so over 1 million assessments that's collected on a routine basis. The data that we use to create the predictive algorithm spanned over, I believe, about 5 years. And we started with 400 elements, but we obviously want a more parsimonious model. So we took the most influential variables within those 400 elements, and we came down to a list of about 25. And I'll show you what those 25 look like. And those are 25 variables that are most predictive of people's survival time. And so where Homer was using data in acute care setting, we're using routinely collected data at the community setting through these RIE assessments. We can get to the next bullet or next slide. Okay, so what we've done, again, we took 400 variables and we asked which ones were most predictive. And these are the results of the hazard ratio. So hazard ratios basically tell you how much more likely you are to die, or how much quicker you are or how much closer you are to death if you had that particular variable versus if you didn't have that particular variable. End-stage disease is sort of like a surprise question. It asks whether or not someone has told you that you've had less than 6 months to live, or that you're close to the end of life. And you can tell that people who have been told that or it's been recognized that the person is in their end stages or dying months, they have a 3.4 times higher chance of dying. Whereas we looked at also symptoms of health decline, vomiting, shortness of breath, weight loss. And these are symptoms that are thought to be associated with how close you are towards death. And you can tell that they're moderately predictive. So in the range of sort of 20 to 30% increased risk of death. You can go to the next slide. So this is part of the adjusted model. So these are all variables that were chosen in our final respect model. And these hazard ratios are adjusted for all the other variables that were included in the model. So when I showed you end stage, for example, that accounts for people's age, sex, and all the other variables that I will show you now. The next thing we want to look at is people's level of function. So James talked about ADLs, activities of daily living. So that's things like being able to dress yourself, being able to bathe yourself, being able to feed yourself. IDLs are a higher level function, so being able to cook, shop, clean. And as we get closer to the right there, we have more and more restrictions. So IADL 6, for example, are people who are completely dependent for their IADLs. And IADL 1 is people who are completely dependent, or actually 0 is completely dependent, which is our reference group. But IADL 1 is just slightly moderately impaired. And you can tell that IADLs and ADLs are quite predictive as well. So someone who's completely dependent for their IADLs or ADLs have almost a 2 times higher risk of dying. And this is again accounting for all the other variables that are in the model. So if you go to the next slide, please. One thing that wasn't that predictive was actually the chronic conditions that people had. So James talked about the different sort of trajectories that people can have as they get closer to death. And you can see here that congestive heart failure, CHF, people with CHF did have a higher risk of mortality. But once you accounted for ADLs, IADLs, people's age, sex, end-stage disease, their symptoms, then all the other diseases are not that predictive. So having diabetes or having obviously heart disease or dementia was only mildly increase your risk of death when you accounted for all the other people's characteristics. So if you go to the next slide, please. So when we looked at the model, what we did is we split our sample into our derivation cohort, where we create our mathematical equation to predict people's risk of death. And then the other half of the cohort, we used to sort of validate our algorithm. So how accurate is our algorithm in predicting death in individuals that weren't used to create our model. And you can see here on the y-axis is predicted mortality. So this is the mortality that the respect equation or algorithm spits out from 0 to 1 or 100%. And observed mortality is obviously just that, the observed mortality for these individuals. And this is over a 6-month period, I believe. And what we did was we took everyone in our validation cohort, so the people that we didn't use to create our tool, and we broke them down. We gave them the respect scores, and we kind of sorted people into 20 distinct risk categories. The X on the top here, I guess you can't see my pointer, but the X that's associated with 50% observed mortality and predicted mortality, that's that shows you that the predicted mortality is quite close with the observed mortality, and that 45-degree angle line tells us that if you're on that line for each of these groups of people, then you have pretty good prediction, and you can tell that the observed and predicted mortality is fairly close. So it's performing pretty well, similar to what Homer is doing as well. So if we go to the next slide. So James talked about automation, and so respect is being automated because again, right data is being collected on a routine basis. So right data is collected both in the home care setting and in the long-term care setting, and we've taken the respect algorithm, and I'll show you the different settings that we're applying it to. But what we wanted to do as well is create a tool that people can use, individuals, patients, caregivers can use to come up with their own survival time. Because we wanted to, I think James showed you all the barriers to providing prognostication and delivery of palliative care. One of them obviously is clinician time. And what we want to do is circumvent that and, sort of give this tool back to patients so that they or their caregivers can provide estimates of their prognosis independent of that care practitioner. So if I can, what I'll do, if I actually go to the next slide, please. I think I have, a case. So if you can just put up all the bullets there. So what I'm going to do, and some of you have seen this, so apologize if this is a repeat for some of you who heard me talk, but this is a sort of a case where, where I think most of us, who are clinicians would have a difficult time, providing prognosis. So I chose a case, sort of a random case, but a case where, it's not cancer, it's someone with dying of other conditions. So in this case, COPD. And I'm going to go through the characteristics here and then put it into the respect tool to kind of show you, what kind of additional information it can provide. So Mr. Johnson, he's a 74-year-old retired electrician. He has multimorbidity. So he has heart disease, coronary heart disease, congestive heart failure, and COPD. In terms of his ADLs and IDLs, he's having some difficulty with meal prep and housekeeping. And that this difficulty has been increasing over the last 3 months. He does also have some difficulty getting around and using the bathroom. So those are ADLs. He's on oxygen a couple hours a day for his COPD, so quite end-stage COPD or quite severe COPD. And he's just been recently discharged from the hospital for his COPD, for a COPD exacerbation. He's experiencing some weight loss since being discharged a couple of days ago. The physician wouldn't be surprised if he died in the next 6 months. So that's sort of the end stage kind of variable that we included. But, he's just been discharged and he's actually, looking forward to recovering and attending his weekly card game. So this is a case not very atypical. I would say it's very typical to have someone like this who's just, gotten out of hospital, has regained some function and would like to kind of regain that function. The question with someone like this is, what is his prognosis? What is his life expectancy? And should palliative care be involved now or soon, right? And I want, all of you who haven't heard me talk about this, but to kind of guess in your head, what kind of prognosis, does this person have? And, as a clinician, without, actually using the respect tool, to be honest, if this person was in front of me, I would have a hard time telling them, this is, for someone like you, this is, what you can expect in terms of life expectancy. But I'm going to show you we don't, that we don't need to guess. taking all these variables, we don't have to just use our clinical judgment or gestalt, but we can use the data to spit out information or survival prognosis that's in keeping with other people's experiences. So other people who've had similar conditions, what was their survival time? And if you can I start sharing my screen now? And I'll run through the respect tool. Okay, perfect. Hopefully this will work. Okay, so this is the respect tool, and anyone on the webinar can use it. The link and the password is there. So this right now is password protected. We have a paper coming out in CMAJ that kind of describes the respect validation piece. And once that's out in May, then this will be available freely available for everyone to use as well. So this is the respect tool. We have some caveats here about what the respect tool is and who should be using it, and about the science, and about some of the caveats about some of the disclaimers about what information that this will give you. So I'm just going to click begin here, and we're going to fill this out on the from the viewpoint as a clinician. But if you click me or a family member, then the wording of the questions will change to kind of make it more aligned with what people might more easily understand. So this was obviously calculator was created for people using home care because it was created through RIHC. So we're going to say yes, we know that that's the case, and we're going to enter Mr. Johnson's information. So we said he was 74. We said he was an electrician, so he completed trade school. We said he had congestive heart failure, coronary heart disease, and COPD. And it's a surprise question. Does your patient have a prognosis of less than 6 months to live? So in isolation, I show you that, and James has showed you that it's not great. But what we find is when we account for this question along with all the other variables, then it doesn't perform too badly. So we're going to say yes. And as we answer these questions, what respect does is it provides you some information back. So it sort of gives you an indication of what's affecting this person's prognosis. So we have this frailty bar first. One of our knowledge users wanted this, but I'm not sure how helpful it is. But we have different metrics here that we present. And with the idea that we want to present metrics that might speak and be reachable to people in the general, in the public. And so we do have our typical, 3 month, 1 year, 5 year risk of death. So without knowing anything else, Mr. Johnson with his chronic conditions, at 74, who's been told that he might have less than 6 months to live, this is his 3 month, 1 year, and 5 year chance of dying. We know that this is something that clinicians are used to, for example, in the cancer world, but we know that a lot of people have trouble with probabilities and understanding probability of death. So what we wanted to do is create sort of a different metric. And this is the metric that I think will stick to and will resonate with most people. And this gives people their life expectancy for people with the same responses as what they have. So in this case, without knowing anything else yet, for people with these same responses, the median life expectancy is 2.3 years. And what we want to do, obviously this is a point estimate, but there's a whole range. And so we want to give some idea of range. So we give the IQR here. So 25% of people died within 10 months and 25% of people survived past 4.4 years. There's a date function here if, to make it sort of bring it home so that, that 2.3 years, translates to summer of not next year, but the year after, for example. So what I'm going to do is I'm going to fill out the rest of the information here. So we said that he had some difficulty, I think, with meal prep and housekeeping. And we're going to say that he had some difficulty with these tasks. And you can tell that life expectancy starts changing as we put in that information. I think we said that he also had trouble using the bathroom and getting around the house. And we're going to say that he has limited assistance with these tasks. Obviously, if you increase the level of dependency, then the marker of life or the estimate of life expectancy changes. And I think we did say that their level of ADLs have gone worse over the last 3 months. So if we click yes here, you can tell again that their life expectancy will change for the worse. I'm going to skip a whole bunch of these other questions. I just want to go to the oxygen question. So we said that, because of the COPD, he's using oxygen. And, this asks us whether or not he's using it or whether he's actually not using it. So we said that he is actually, in fact, using it, full adherence as prescribed. And you can tell that life expectancy goes down to 8 months. We said that he was recently hospitalized and visited the ER over the last 3 months. And you can tell with that, full set of information, this person's median life expectancy is 7 months, and 25% will die within 8 weeks. 25% of people survive past, 1.9 years. I think if you look at this life expectancy and, you think of this person as not having COPD, but as having cancer, I think it's I don't think there's any doubt that, palliative care, for example, should be started, right? That conversation should be initiated at this point. There's this date function. So for people with the same responses, on average, they survive until fall of this year. And again, I think really brings home the message, about how long people have left to live. And some people do, survive past March 2023. But again, I think, for most people with this prognosis, most clinicians would say, yes, palliative care might be appropriate for this person. Obviously, it's very individualized to the person's needs, but as a first step, this gives you an idea that you should at least be considering palliative care in this patient. Okay, there's also, a sort of a resource page that people can print out, create a PDF and send to their family physician, for example. But I'm going to stop there about the respect tool. I'm going to stop sharing. If you can throw up the slide again, I think it's Jasmine or Caitlin who's controlling it, and then I'll stop after 30 more seconds. Okay, if you can go next slide. So, I should just show you the respect tool. And so again, it's going to be freely and available to general public late May. What we're doing, apart from that individual perspective where people can use it, what we're doing similar to Homer is we're integrating respect into data systems that are routinely collecting this data. Again, clinicians are busy. If you ask them to fill out this, they might, fill out with patients. But what we wanted to do, similar to Homer, is, have it run in batch mode, in different EMRs, so that we can spit out, just like Homer, lists of patients who might benefit from a palliative care approach. So we're doing this in some long-term care homes. We're doing it in some complex continuing care hospitals. We're integrating into home care. So we have a trial pilot project for retirement homes across Champlain. And apart from survival, I just wanted to note there that we're trying to expand respect into different patient populations, but also different outcomes. So not only looking at survival, but also looking at quality of life, for example, and then looking at different populations like people with dementia, people who've contracted COVID, and using different predictors. So Respect now actually uses some of the variables, some of the labs from Homer. And Respect Me is something that we haven't started yet, but will integrate mobility enhanced. It will enhance our prediction using sort of accelerometers, so people's level of function through things like wristwatches. Okay, so I'm going to stop there and throw it back to James to finish off. If you're there, James.
James is here. Okay, do you want to go to the next slide? So yeah, again, just coming back to this arc that we talked about, and I think it's a great chance for you to see some examples of how automated tools might be able to help us overcome some of these barriers on the assessment and identification side of the arc. Again, if you're overwhelmed, you're unable, you're unwilling, the tools are inaccurate, this kind of jumps all of those problems and does so in what we hope will be a sort of workload friendly way. It can also be used to drive interventions delivered by all kinds of people. So the burden of identification and action doesn't have to fall on one individual like a doctor or nurse or a nurse practitioner. And I think in an ideal future state, you see, Peter showed you a variety of different respect variants, not variants of concern, obviously, which is fortunate, but these are just variants. And Homer's got a new version called Homer Now, you have to say now very loud because there's an exclamation mark, which is a version that actually incorporates certain clinical information like blood work results. And is a little bit more accurate as well. And we're currently in the process of rolling that out at 14 facilities, have confirmed participation. We have another 5 that are likely to join. And we just received a grant from CIHR to help implement and study the effectiveness of this. Ottawa has developed an EPIC version of it that's going to be rolled out in a few places, and Alberta will likely pick it up, but it could go from there. And you could certainly see, a number of these kind of companion tools working in different sectors. Wherever there's data, you can build a model, right? And having a lot of these little models kind of working together towards the same goal of just identifying patients at high risk and helping to drive improvements in end-of-life care. So obviously there are still, barriers that remain. For example, overwhelmed physicians still can't necessarily act if they're not skilled at communicating or providing therapies, if there's no resources, if the family's unreceptive. Homer and Respect won't fix any of those. But there are interventions that may help, and those interventions may be driven by Homer and Respect, and that's really the paradigm that we're going towards. Next slide. So yeah, there's no magic bullet. You're going to require a lot of different things to overcome all the barriers there. But again, identification and assessment, which has already been included and equipped for many facilities, even from 2019, 2020, is there. We're moving in this direction, and hopefully down the road we'll see some more standardized interventions that can be delivered and tracked, and those can become quality metrics rather than just the identification process. And again, all of this in the interest of driving a quality agenda forward. So I think that brings us to the end. Next slide. So feasible, acceptable, feasible workload with a high burden of unmet needs, preferentially identifying groups that are neglected, versatile, possibly effective for changing care, and really just the basis of a QI intervention. And that's all. Thanks. I think there's one more slide.
We're at the end there. Thank you so much.
Okay. So thank you for your attention. I don't know if there are questions or how you want to do this part.
Yeah, so I think we've received one question so far. Where does long-term care fit into the bow tie model, as it's not hospice or a palliative care unit?
This sounds like a Peter question.
Can you remind me what the bow tie model
Sorry,
is?
the bow tie model, I'll answer that. The bow tie model is the Pippa Hawley thing where you have the sort of blue triangle and the pink triangle. The long-term care is a setting, right? It's the same question, right? That you're applying, that whenever somebody goes to long-term care, median survival 12 to 18 months, depending on which building you're in. So just being admitted to long-term care is equivalent to having, chances are the reason why you're there is a chronic underlying incurable condition, which will eventually be associated with unmet needs if they aren't currently. So applying that while still trying to help people recover, and help keep people stable is still the paradigm. I mean, somebody who goes, long-term care admissions usually aren't like temporary. Most people tend to stay there. They don't tend to sort of get better after a few weeks and then go home. But the idea that you're sort of still being co-managed and making sure that your palliative needs are being met is really key. And that's why Respect is so important, because 25% of the Ontario population, 25% die in a long-term care or are long-term care residents who die. If you're not doing palliative care in that sector, then that's a huge gap.
And to quickly add on to that, James, I think most people are not, most of my patients, when they go into long-term care or their caregivers, don't really know that it's actually that's the prognosis, right? And so, people have sometimes unrealistic expectations, or not unrealistic, but goals of care that are not aligned to people's prognosis, right? And that's why, automation tools, both at the clinician level, but also, giving information back to patients and caregivers is very helpful, right? Because I think if you told them that they have, again, 6 months to live, I think, sending them to the emergency room or, which is quite burdensome, you might second guess, whether or not you want to do that, for example.
Thank you. We have a couple more questions that have rolled in. Can you talk about the next steps for the Homer research?
Yeah, I just alluded briefly to it at the end, but we've got, so it's kind of at various stages of rollout. Obviously, we picked a fantastic time to engage in a provincial level QI initiative. It was beautifully timed. We were literally rolling it out. We had a face-to-face meeting in February of 2020. to sort of a couple of hospitals had launched it. You can't pick your timing, and it's going to screw up a little bit the before after analyses that we're doing. But the data that a lot of projects that were put on hold for the better part of a year for obvious reasons. And we have nothing to say about that, of course. But the data that's come back so far is pretty impressive in terms of how effectively it has driven people to do these sort of standardized assessments. That the purpose of this tool is to make sure you're getting assessments in on patients who are in high needs. And it appears to be doing that very effectively. But this ultimately is it's not a technical challenge, it's an implementation challenge, right? It's not figuring out how to make the computer do what you want it to. It's about figuring out how to make the computer work well with the human, right? That this isn't artificial intelligence, this is augmented intelligence, right? This is just helping you as a decision aid, the same way that lane changer beeps when there's a car in your blind spot, or if you're getting close to, your kid's tricycle as you're backing out of the driveway, you hear a beep, 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 because that's where the car helps you, because that's where humans are known to make mistakes. And so, we're trying to fill in those gaps and make sure that those things don't happen. Building onto this then, and building onto respect as companion tools for each other, to then drive the more standardized things like serious illness conversations. We have a medication deprescribing intervention that you could link to it very easily. There are lots of different interventions, many of which are partially or totally automated, that you could also add on. So it's sort of, the first step is the identification assessment part, but then building the interventions on top of that. That's the future.
Well put, thank you. I think we'll try to squeeze in just one remaining question. Knowing low Homer threshold still identifies a lot of unmet palliative care needs. This respondent is wondering why we need to get more accurate with mortality. Isn't the unmet palliative care needs the primary driver to determine palliative care resource allocation?
Well, yeah. Oh, sorry, go ahead.
This person would rather have a specialist palliative care provider see patient with high palliative care needs, even within 2 to 5 years of prognosis, compared to a patient with low palliative care needs but short mortality.
If I would love us to be at the point in our evolution where people are like, damn it, these people with 2 to 5 years left just aren't having their palliative care needs met. That is not the world we live in. I just have to be really direct and say that is not the world we live in. 1% of the people who get palliative care get it for a year before they die. 99% get it for less than a year. And the vast majority get it less than a couple of months. And some get, a large proportion get none at all. So I would love us to be having arguments about 2 to 5 years. We need to start turning weeks into months, right? That's any conversation that is about years. Let's work on months before we work on years. That's my point there. It's not that these people don't have needs. It's just that they're not the highest priority. They should not be the highest priority, in my opinion.
Yeah.
That's great. Thank you so much. I think we're out of time. If anyone wants to follow up, you're welcome to contact us at briirb@bruyere.org. The email address is listed in the chat if you have any additional questions you'd like to forward. And if you enjoyed today's talk, we have another one coming up April 22nd. The registration link is also in the chat if you'd like to join us again. Dr. Downar and Dr. Tanuseputro, thank you so much for your time.
Thank you very much. Everyone stay safe.
Yeah, take care, everyone.
Bye.
Bye-bye.